Hello and welcome to today's webinar on stereotactic radiosurgery for trigeminal neuralgia, current concepts and limitations. Our presenter today is Dr. Manjul Tripathi, Associate Professor, Department of Neurosurgery at the Postgraduate Institute of Medical Education and Research, Chandigarh. Dr. Manjul was a former faculty at NIMHANS, Bangalore. He has over 100 research papers and is a recipient of several awards. He completed his fellow functional neurosurgery from Oxford and skills training from AIIMS, New Delhi. His areas of interest span functional neurosurgery, gamma knife radiosurgery, neurotrauma, and skull-based neurosurgery. He last month published his first book, Krodh, originally authored by Antonio de Celis. Krodh is a Hindi translation of the bestseller, Why Fly Over the Cuckoo's Nest? It's a fiction on psychosurgery which deals with issues of anger management, obsessive-compulsive disorders, and psychiatric illness with the help of neurosurgery and radiosurgery. In essence, it is an extension to the routine radiosurgery. Okay, so before we begin, I would like to cover a few housekeeping items. At the bottom of the screen are multiple application widgets that you can use. All the widgets are resizable and movable to move them around to get the most out of your desktop experience. And your slide area, or minimize it by clicking on the arrows in the top right corner. If you have any questions during the webcast, try to answer them at the end of his presentation. Do note that some networks cause slides to advance more slowly than others, so logging off your VPN is recommended. If your slides are behind, pushing F5 on your keyboard to refresh the page would help. You can find additional answers to some common technical issues located at the help. So without further ado, over to Dr. Manjul.
Thank you, Karan, for this nice introduction, and good afternoon, everyone. I am sincerely thankful to Electra to ask me to speak on this difficult and philosophical disorder of trigeminal neuralgia. This disorder needs a special mention in neurosurgery, as a general neurosurgeon is more at a risk for defamation if the patient does not get a satisfactory pain response compared to any other illness. So these are my disclaimers. I am Dr. Manjul Tripathi, a microsurgeon and radiosurgeon at prestigious Postgraduate Institute of Medical Education and Research, Chandigarh, India. And I have been practicing gamma knife since the time of my neurosurgery training. I have experience on working on both foci and perfection, and there is no financial disclosure for this talk, and I would appreciate your queries and comments at the end of this webinar to make it more interactive. Just to take you to my place, it's in the foothills of Himalaya near capital New Delhi. It's a beautiful place. My hospital is a public sector hospital taking care of nearly 80 million population of nearby 7 states. And the history of gamma knife in India dates back to 1996. My center was the latest, having perfection, and we treat 500 and more patients per year. Most of the indications are actually the benign pathologies, vascular pathologies, and functional disorders. And the number of the metastatic disease is a little less in India. Trigeminal neuralgia is a philosophy, and I am sincerely indebted to Professor Douglas Konjolka, John Regis, Tony Sales, Alessandra Gorgulho, and my dear friend Konstantin. None of them have actually taught me directly, but I have been reading and listening to their valuable treasure of articles and lectures for last 1 decade, and I personally take advice from them sometime and learn the nuances of radiosurgery for trigeminal neuralgia with them. So before I start my talk, let me be very clear that I do not contest the gold standard treatment status of the microvascular decompression for trigeminal neuralgia. MVD is the benchmark. I have no doubt in it, and the literature supports my statement. However, it is not the safest. It is an invasive procedure, and in my own personal experience of nearly 110 patients treated with MVD, 2 of my own patients developed facial paresis, 1 developed infection, and 1 re-exploration for the CSF leak. I practice gamma knife radiosurgery and MVD both, sometimes radiofrequency ablation also. Among all options, the gamma knife remains the safest modality with nearly equivalent efficacy, which I am going to discuss you. So I would like to know a little about my audience. What is your primary treatment option to any patient of medically refractory trigeminal neuralgia? Is it stereotactic radiosurgery in your approach, or radiofrequency ablation, microvascular decompression, or balloon decompression? So you can choose one of these options as per your preference, and then we can have an idea what are we going to discuss today. So it's I'll give you 10 seconds time to answer this query. Oh, wow. Am I the only one who has answered it? Because it's 100% stereotactic radiosurgery. So that's pretty interesting. Trigeminal neuralgia is a nightmare for any patient and sometimes to the treating team too. For my international and non-Hindi speaking friends, he's Salman Khan, one of the most popular Indian film actors. He's a patient of trigeminal neuralgia, and thanks to him, the ordinary people have also started noticing about this disease. He has also received gamma knife for this disease and is currently doing well. Most of the time, the neurosurgeon is not the primary person to take care of these patients. Patient primarily goes to ENT, dentist, neurological colleagues, and pain clinics, and then get referred to the neurosurgeon when the treatment becomes refractory to the medical management. And because of the lesser awareness, there are frequent questions like, does gamma knife really work? Are long-term results available with gamma knife? Can it be used for the recurrent pain? Can gamma knife be used as a primary treatment option? Is early radiosurgery effective in pain control? Can it be used in the failed cases as well? We are going to discuss all this. So let's discuss trigeminal neuralgia with a little introduction to its definition, the current status definition, how to make a diagnosis, what are the cafeteria choices, when to offer SRS or gamma knife radiosurgery, indications, outcomes, complications, SRS among other options of treatment, and the controversies prevailing with the SRS. The diagnosis of trigeminal neuralgia begins with the treatment of the trigeminal neuralgia begins with its correct diagnosis. And I am really sad to say that this is one of the most wrongly diagnosed entity in the clinical practice. As I have earlier told, that trigeminal neuralgia patients never visit you as a primary consultant to check. They go to the ENT or the dentist. And I have seen in my own practice people coming with nearly 4 or 5 dental procedures done on them because they thought that the pain is arising from some root canal or something like that. And when it becomes refractory, then they send it to somebody else, and then they get diagnosed as a case of trigeminal neuralgia, and then our role comes. So the gatekeepers sustain a very important role in the management of trigeminal neuralgia. Make a correct diagnosis on the first hand, check it, recheck it, and only once you are sure, go with the protocol-based management. It is also very necessary for you to diagnose it correctly and treat it in a protocol-based manner, because it is one of the most common reasons for the litigation. Among the causes of litigation, the second most common reason has been failure to diagnose, and the first is the surgical complication. That's pretty understandable, but failure to diagnose in around 33% of these patients has been the reason for the medical litigation. So you can see that the defendants were mostly from the dentistry and from the neurosurgeons. Nearly 20.4% defendants were the neurosurgeons. So it is very necessary to safeguard ourselves by diagnosing it correctly and by making a realistic realization and the explanation of the outcome and the possible complications to them. The definition of trigeminal neuralgia has been updated several times. The key points are unilateral pain lasting for a few seconds to few minutes, arising spontaneously, occurring in paroxysm, abrupt in nature, and triggered by innocuous mechanical stimuli. The patient may be completely pain-free in between. Usually the pain occurs in the daytime, and very rarely any patient tells that he got up because of the pain in the night. If you just go with the diurnal cycle, you will find that this is mostly in the day and not in the night. And one crucial indicator of the diagnosis of trigeminal neuralgia is that it gives a very good initial response to carbamazepine or oxcarbazepine, but eventually the medical management fails, and the patient either becomes intolerant to the drug therapy or they start getting complications because of the drug therapy, and then we need to move on the second line of management. Excuse me. Broadly, it is categorized into the three etiological categories, like the idiopathic trigeminal neuralgia, when it occurs without any cause. You are not able to find out anything on radiology. Classical, when it occurs because of the vascular compression of the trigeminal nerve. And the secondary trigeminal neuralgia, when you find some other skull-based tumor, multiple sclerosis, or the neurological disorder, and in its ramification, you find that in that disease spectrum, trigeminal neuralgia is also a component. And there are several very well-defined protocols to evaluate a patient of classical trigeminal neuralgia, and an MRI is actually a must to rule out other possible pathologies if they are responsible, and then neuralgia for any other skull-based tumor. So it becomes a classical trigeminal neuralgia or secondary, and if you are not able to find any pathology, it becomes an idiopathic trigeminal neuralgia. I always start the treatment of medical management with the minimum possible dose of carbamazepine. Nearly 50% patients achieve satisfactory outcome for a good time. They become pain-free. And this is also helpful because a patient coming with the pain, if you at the first hand you tell about the surgery, they get really anxious. So it gives a security to them. Your colleagues in the allied specialties also remain happy with that. But in nearly 30% of these patients, when you get an MRI, you do not find any conflict. The reason might be such a minuscule blood vessel that it doesn't appear adequately on the MRI. Nearly 25% patients do not benefit adequately with the initial medical management. And eventually, all of these patients fail because either the drugs getting metabolized in the body or the patient becomes resistant, as we all know, and most of them would need additional procedures in their lifetime for the management of the pain. The interesting fact is that there is no definition when to call it a medical failure. So I see people walking in OPD for even more than 2 decades with a cocktail of medications. When some physicians offer them a surgical option, they change the physician. The next one adds a new drug, sometimes just an antidepressant, and assures that they would be okay for a good time. And sometimes they just start following other alternate treatment options like the Ayurveda, homeopathy. But common sense says that if a previously managed patient controlled on 2 medications now gets uncontrolled with the maximum tolerable dose, or is not tolerant to the side effects of them, it's a failure now. So let's move ahead with the next treatment options. And that's an interesting article on the issue of the medical failure. Juana evaluated the consumer's views on the treatment options for trigeminal neuralgia and to compare their assessment with those of the clinicians. The carbamazepine and oxcarbazepine, both of these drugs actually cause multiple side effects. Important are drowsiness, cognitive impairment, cerebral symptomatology in the high doses. These are dose-dependent side effects, and the long-term medical management leads to the side effects, which tends to be underestimated by clinicians. And in the absence of any definitive evidence, patients currently find it difficult to make decisions about treatment, as the caregivers are also frequently confused. And you can see here in the conclusion, the therapy leads to the side effects, which tend to be underestimated by the clinician. So we continue patients on medical management for a very long duration of time, which is not right in the patient's sake. So when Professor Lars Lexell was perplexed on the issue of the poor results with conventional neurosurgery, he envisioned stereotactic radiosurgery with the primary indication in the functional neurosurgery. And it was planned with the high dosage, early lesioning with the gamma knife. And in 1951, he treated first patient of trigeminal neuralgia with Lexell frame and an orthogonal X-ray tube. The target at that time was the Gasserin ganglion, and the patient had good pain relief for over 18 years. That was pretty impressive. But in 1963, the carbamazepine was introduced, which took good care of most of the patients for a short duration of time. And while localizing the trigeminal ganglion, glycerol injection was used by Professor Lexell also, and the tantalum was there. And they found that it in itself gave a good, sufficient pain control, and Lexell lost his initial interest in the radiosurgery for trigeminal neuralgia. So it's a long journey. The first procedure by Lexell, and then the Hackinson used the Gasserin ganglion injection. In mid-80s, we got better with the MRIs, and then we had the DRES. In 1996, a cooperative study on the role of the radiosurgery was done, and in 1998, with the better imaging and improved techniques with the gamma knife also, the gamma knife was resurfaced as an effective treatment modality. So the cases initially done by Lars Lexell were pretty less, and then in his article in JNNP, Professor Lexell clearly mentioned that there is no fixed rule as far as radiosurgery is concerned. That dates back to the 80s. And now you can see the change. Because earlier he told that from these observations, no definite conclusion should be drawn concerning the optimal dose of radiation or the exact mechanism and site of action in the root or the ganglion, or even the general applicability of the method. So there was some confusion in the early times, but now the literature shows that nearly 90% of the functional indications are trigeminal neuralgia, and it is one of the most common pain procedures to be treated with stereotactic radiosurgery. The things gradually got better for imaging and even for that matter gamma knife technology, and the new concept came to move the target from the Gasserian ganglion to the root entry zone. And one important contribution was by this article published in JNS in 1996 by Douglas Konczolka. This article detailed the multi-institutional analysis of radiosurgery for trigeminal neuralgia and re-established the role of SRS in the management, as it also could answer crucial questions on the issues of radiosurgery. You can see the impact that in 2019, more than 81.5 thousand patients received gamma knife treatment for the trigeminal neuralgia worldwide, and this graph is gradually increasing. That shows its effectivity and its acceptance among the general public population and the physicians alike. There are different machines used for the SRS, but the most accurate and the popular in this regard is the gamma knife radiosurgery. This article is a reflection on this journey, and the gamma knife is steadily increasing and maintaining its position as the most practiced radiosurgery tool. The literature is also more and more robust now, and if you search gamma knife radiosurgery and trigeminal neuralgia, you will be able to find nearly 750 research articles in the PubMed. So that remains the most celebrated article to highlight the role of radiosurgery, because it established that how to identify the appropriate dosimetry parameters. It told about the short and the long-term outcomes and the risk of the complications. And following this article, the literature got flooded with the good long-term results of radiosurgery in these patients. If you like the history of everything as I do, I encourage you to read this article by Alessandra and Tony Salis. That is the impact of radiosurgery on the surgical treatment of the trigeminal neuralgia. It's a good read. Some common points when we do gamma knife radiosurgery: we do 1 millimeter thick cuts, continuous non-overlapping cuts, especially with the CIS and T1 and the contrast images. And we target the cysternal component of the trigeminal nerve. What I practically follow is the Marce point, which is somewhere around 6 to 7 millimeter away from the brainstem from the ores. And we use a single 4 millimeter isocenter. That's the minimum possible size of a collimator. And the dose is capped at 70 to 90 gray. What is the best target point? That's a very frequent question which we ask when we treat with the gamma knife radiosurgery. Where is the sweet spot? Well, there is a conflicting literature and different schools of thoughts on it. You can target the root entry zone, as in the figure C, or in the cysternal component of the trigeminal nerve, as in the figure B and D, or you can target the distalmost cysternal component of the trigeminal nerve. Every point has its own benefits and disadvantages as well. But what is currently practiced is the one with the distal component of the trigeminal nerve somewhere around 6 to 7 millimeter away from the brainstem. Why? Because I'm going to come over it. Why is it a preferred spot? A trigeminal nerve takes origin from the pons and ascends towards the Meckel's cave. Contrary to the popular belief, the ores is not at the fixed point. You can see it here in the T2-weighted images, and it may be at, it's a fanning appearance when there is a transition from the central myelin to the peripheral myelin, and it goes into the Meckel's cave, the trigeminal nerve, and then it divides into the 3 branches. The different treatment modalities have different points in the target. Once we treat with a gamma knife or MVD, we try to treat at the ores or in the cysternal component of trigeminal nerve with the glycerol, balloon, and the radiofrequency ablation. That remains in the Meckel's cave, and that is the reason they have a higher sensory complications also. And with the peripheral neurectomy, we go further distal. Now the question arises, how much dose is sufficient with gamma knife? Well, the dose is preferably in the 80 to 90 gray. Anything less than 70 gray is of no functional benefit. More than 90 gray causes the nerve necrosis with no further improvement in the pain control. So while in the range of remaining between 80 to 90 gray, it causes nerve modulation and stops trigeminal neuralgia. Various studies evaluated this concept and found that the dose escalation for trigeminal neuralgia to doses greater than 82 gray is associated with an improvement in the pain control in response to the treatment, and duration of the pain relief. Patients treated at these doses, however, should be counseled about the increased risk of the treatment-related facial numbness when you increase the dose above 82 gray. So as you go higher, the pain control would be better, but it may come with a little cost of some sensory deficit. While planning the treatment, it is very important to preserve the brainstem from unnecessary radiation. And how much dose to the brainstem is tolerable, that remains a disputed answer, but conventionally, brainstem should be preserved from more than 12 gray radiation, and not more than 1 cc of the brainstem should be exposed to more than 15 gray of the radiation. There are guidelines which are published by the AARB and the ESCO. So you can see that the brainstem should not be exposed to more than 18 gray in a single, 15 gray in a single fraction. The commonly asked question is, how does gamma knife affect trigeminal neuralgia? What is the modus operandi? In a baboon model, the consulta targeted the trigeminal nerve and did microscopic evaluation on the autopsy specimen later on. The nerve shows signs of the axonal degeneration. There is non-selective destruction of the nerve fibers, the A delta and the C fibers, the fibers which are involved in the pain transmission, with the focal gliosis with reduction of the axonal contact and aphaptic transmission, which is a seizure-like activity in between the nerve fibers causing the transmission of the nerve. The peripheral myelin is more radiosensitive than the central myelin, and the non-necrotic radiation doses less than 100 gray should be used. If it is more than that, it causes the nerve necrosis, which has been shown in these figures. So this is the normal nerve, and these are the irradiated nerves with the necrotic component. And this is an interesting study which actually challenges the role of the root entry zone. Authors found that the central myelin is much more radiosensitive than the peripheral myelin. You can see here the myelin by the oligodendrocytes and myelin with the Schwann cells, and the radiation sensitivity is different of these two. To answer these very questions, Mosgan Hodai from Toronto University evaluated the trigeminal nerve both before and after gamma knife, and they found the focal axonal degeneration at the site of radiation delivery. With the diffusion tensor imaging, she was able to pinpoint the changes, and changes were highly focal with the radiosurgery. After gamma knife, some of the patients tell that they get an immediate pain relief, while several of them do not get adequate relief even by the end of third month. And practically, if somebody tells me that they got an immediate pain relief, it might be just a placebo effect. In my clinical experience, the patients get a relief somewhere around in between from 3 days to 3 months after gamma knife, mostly within 2 weeks. And the literature is not sure when should I say that SRS has failed in a particular case. There is no definite timeline to answer this question, that when can I say that SRS has failed in my case. But conventionally, if the patient does not respond even by the end of the 6 months, I consider that the patient has failed with the SRS. The pathological studies may answer this question, why some patients have an early relief and why some have a late relief. The radiation effect on different individuals may take different timeline to act, and this timeline varies from a few days to 12 months, but average is 1 to 2 months. And this review article by Otabi found fibrotic lesions with the axonal degeneration after radiosurgery in patients who have actually achieved a good pain control. So if someone is actually having an immediate pain control, there are high likelihood chances that they are going to have a long-term good pain control. Somebody who is having a poor control in the initial 2 to 3 months, then their likelihood of having good pain control is the long-term also diminishes. So early pain relief is a good indicator for gamma knife. So let's again a question. I would like to know more about you, and do you think that SRS provides adequate pain control to your patients up to 3 years after treatment? So till now I have just talked about the early pain relief. Now the question I am asking you, whether you think that your patients have a long-term pain relief, yes or no. We have 10 seconds to answer this query, and then I would like to know about your perspective over it. So 100% we are having all think that it's providing a good pain control, and that's a good, yes, it's most of the patients it's able to do that. So I would like to know about, sorry, it just jumped. Yeah. So to optimize the radiosurgery for trigeminal neuralgia and to have a long-term pain control, the literature advocates optimizing radiosurgery by prescribing a higher dose on a distal anatomical target. You can see that this is the cysternal component of trigeminal nerve, and after this the nerve is just going to enter. On the right side of the image you can see that this is just going to enter into the Meckel's cave. In this review, the authors found that targeting a distal point significantly enhances the pain control without causing a bothersome numbness. And these 4 studies particularly evaluated the long-term outcome. Like Dhulpe et al. With the 102 patients treated with a median follow-up of 5.6 years. They found that by the end of 7 years, 22% of patients had a pain control. Initially, it was 41%, and bothersome hypoesthesia was in 6%. But you should remember that compared to this particular series, the other series had an impressive pain control of 71% and 72%, and the long-term pain control was also good. Konzylka et al. Prescribed 80 gray, and 71% of these patients had an excellent pain control on short term, while by the end of the 7, only 30% remained pain-free. The best outcome was noticed by Regis et al., and they targeted a distal component of the trigeminal nerve with a good dose of 85 gray. The bothersome hypoesthesia overall was seen in only 3%. This was a hypoesthesia which could be easily managed. On an average, it can be told that gamma knife provides high rate of the control of the pain, followed by recurrent pain in nearly 50% patients after 5 years. So up to 5 years, patients remain in a good pain condition, good control of the pain in 50% of these patients. Next 50% of the patients may need some escalation of your drugs. The Dhulpe et al. Had a poor outcome compared to the other one because they actually had a lesser dose given to their patients. Marseille group managed 130 patients of classical trigeminal neuralgia for a median follow-up of 10 years, which ranged from 7 to 14.5 years, and nearly 94% responded within 15 days of the treatment. The first graph shows that after 6 months, the graph gets plateaued, and maximum of the patients respond by that time. The second graph indicates that even the complications which people have, they have in the initial 6 months, and then it gets plateaued and do not worsen. How was the pain control? Actually, the patients, the graph of the pain control gradually decreases down the line 10 years, and the patients may slip from BNI 1-2 status to BNI 5, but still the pain control remains satisfactory till the patients remain BNI 3A. So this is Marseille historical series with the anterior cysternal component called the Marseille point, and this remains the only prospective trial of managing these patients for such a long duration. And you can see that by the end of 6 months, the pain freedom is 91.75%. That's pretty impressive. And for the patients maintaining the pain-free status up to the 5 years is 59.7% patients. So the actual probability of maintaining pain-free down the line 5 years is nearly 50 to 60%. On MRI, I can see here a vessel which is compressing on the nerve. So there is often a question, would gamma knife work in my case if I am able to visualize a neurovascular conflict? Well, it would work for sure. The neurovascular conflict may tell that MVD would be effective, but it does not tell that SRS would not work. It would, and it has been proven repeatedly. So presence of a neurovascular conflict is actually not a contraindication for SRS. By the end of 3 or 5 years, we again encounter patients, nearly 30 to 40% patients who have a recurrence of pain. Now the question arises, should we repeat the radiosurgery or offer them any alternate treatment modality? If the patient has only responded to SRS, so would a repeat SRS be a better option? It would be, but the chances of the sensory complications also increases significantly in those cases. Ideally, it should not be repeated before 3 years to avoid radiation toxicity, but if the patient has not responded up to 6 months, the minimum duration that you need is 6 months. Where should I target? Should I target the same point which I targeted in the primary radiosurgery, or should I target a different point? I'm going to answer this in a different way. So it's no more a virgin case. Would repeat SRS work? The systematic review of the literature shows that the prior response to SRS, longer period of the pain relief after first SRS, and the sensory deficits after prior SRS, they have a positive predicting value. The negative predictors were no earlier response to prior SRS and the prior surgical procedure. There is no definite answer to it, that which patient to retreat, what is the ideal target, what is an optimal dose. The purpose of this study was to investigate how the spatial relationship between the isocenters of the first and second radiosurgeries affect the overall outcome. And what happened to your targeted point? Should I move it? Should I just keep the same target point? The pain control was better with the increased distance between primary and the secondary treatment, and dysesthesia related neither to the distance between the isocenters nor to which isocenter was closer to the brainstem. So if you increase the distance between the two isocenters by around 2.86 or roughly around 3 millimeter, the chances of good pain control increases significantly. There is again a question that, is there any decreased probability of initial pain cessation in classical trigeminal neuralgia who were prior treated with microvascular decompression? The microvascular decompression failed. Should we offer gamma knife to these patients? And the literature shows that actually the initial pain control is not that good as happens for a virgin case, but the longer term results are good and are comparable to those of a virgin case. So in the short term, the pain control might be suboptimal, but in the long term, the pain control is similar. So whether it has been treated with MVD or not, that only has an effect on the initial pain control. In the long term, the pain control is as robust as in a primary case. Now, there are some unique challenges, some unique situations, and these are not the typical or classical trigeminal neuralgia. Trigeminal neuralgia secondary to multiple sclerosis, though it is not a very frequent population problem in the Indian population, but as evident from the literature in the Europe and in the Western countries, this is pretty common. And actually, gamma knife is effective in the short term for this group. I especially like to take your concentration on the Tuleska study, which have found in the 43 patients, they could find that around 90.7% patients had a good initial pain control, and the recurrence was found in 61.5%. So the trouble was that it had a high rate of recurrence to the tune of 61.5%. And mind it, it's a bilateral trigeminal neuralgia in cases of the multiple sclerosis, and the pathology is lying inside the brainstem. So in the initial point, for a short duration, it is safe, effective in the short term, but eventually all of these cases fail in the majority. Similarly, another entity is the dolichoectasia. So sometimes we have large voluminous vertebrobasilar artery. I personally had a hard time. Eventually, I treated 3 patients of dolichoectasia with gamma knife, and all of them had a good pain control for 6 months, but they failed in the long term and needed microvascular decompression. Compared to the classical trigeminal neuralgia, targeting with dolichoectasia sometimes gets easy because it distorts the brainstem and you get a good longer length of the trigeminal nerve. Sometimes because of dolichoectasia, the nerve gets so atrophic that it becomes very difficult to target over there. So that remains a challenge for the radiosurgery. The left image is of a patient. This is one patient who had a dolichoectasia. The nerve was compressed by the vessel, and this patient had an extremely good outcome. The another patient in which even the microvascular decompression was an uphill task because the nerve was below the vessel and it was very difficult to separate it, and probably that was the reason for the eventual failure in those cases. However, the Marcy group had a good experience even with this entity, and even in this group, they treated 29 patients for more than and followed them for more than a year and found that gamma knife had a good short-term pain control up to 6 months to 1 year, and later on they may need additional procedure. The follow-up period was not that robust in the series, and in my own opinion, I initially asked them to go with the radiosurgery with the rider that it may fail in the long term and even after 6 months to a year, and then the MVD would be needed. If the cause of trigeminal neuralgia is any skull-based lesion, so sometimes you can find a small meningioma sitting over the petrous apex and it continuously irritating the trigeminal nerve. Sometimes these are other cranial nerve tumors like vestibular schwannomas, trigeminal schwannomas, or skull-based malignancies. Gamma knife has found an impressive role in cases of the secondary trigeminal neuralgia. The current literature is heterogeneous, but the pain control is modest in the range of 30 to 60% in different series. And Rages found that the initial treatment of tumor should be done, and there are different series which actually target the tumor also and the nerve. In my own practice, I actually target both the nerve and the tumor, the nerve with 70 gray and the tumor with, depending on the tumor pathology, usually it's a meningioma or schwannoma, so 12 to 13 gray. And in these cases, the 5-year pain control is in the range of 30 to 40%. There are certain controversies which we face in day-to-day radiosurgery practice, because all these patients actually continue on some medical management. So should I stop the drugs before SRS? Infrequently, we get an indication that some drugs might be radioprotectant, while it is not so. And in the conclusion, it was found that the use of carbamazepine or gabapentin at the time of radiosurgery does not decrease the rate of obtaining partial or complete pain relief after radiosurgery. So there is no effect of these drugs. In fact, gabapentin may reduce the risk of sensory complications. So a patient having the chances of hypoesthesia, sensory complications, numbness would be less if the patient is continuing on gabapentin as a concurrent therapy while getting the radiosurgery. So should we procrastinate? When should I treat with gamma knife? Early or late? So there is no definite timeline of this treatment. In their experience, Pittsburgh group have found that if we irradiate within 1 year of the pain onset, the chances of pain-free period after gamma knife are also good, and this amounts to somewhere around 5 to 6 years. If we are treating within 3 years, it drastically reduces to 36 months. And if we are treating after 3 years, then it might be probably just 10 months. So the reasons may be atrophy of the nerve and the demyelination. The longer-term pain control is associated with microstructural changes. The demyelination of A delta and C fibers may also have kindling of the secondary sensory neurons, which may affect the outcome. So we should not leave so much time, give so much time to nerve to get continuously demyelinated and start the kindling over there. And in those cases, the long-term pain control might be inferior. Would it be effective irrespective of the patient's age? Oh, yes. Usually the prevailing practice is to do decompression in the younger patients and lesser invasive surgeries in the elderly. The age and sex are no bar in the statistical analysis for SRS. Again, the Pittsburgh group found that the BNI 123 pain control, that is pain control without drugs or with some drugs, is achieved in the trigeminal sensory neuropathy, is seen in comparable age of the younger patients. With the repeat SRS also, the long-term pain control in elderly population is pretty good. This is a series by the Marseille group, and they found that the by the Lunsford group, and they found that even the initial SRS procedure and the repeat SRS, they provided very good long-term outcome. Is hypoesthesia a necessary evil? Because whenever we counsel these patients, the risk of hypoesthesia significantly increases in cases of trigeminal neuralgia. No, there is no need to exchange pain with the hypoesthesia. The bothersome hypoesthesia is seen in only 3 to 6% of these patients. The literature shows the variable response. Nearly after primary radiosurgery, it's seen in nearly around 10 to 20%. It may increase a little bit after the second radiosurgery, but the bothersome hypoesthesia is rare, and most of these patients respond to the short course of the nortriptyline. If you target a distal point, it provides an equal pain relief with lesser chances of the sensory complications. Does beam shaping affect the outcome? So I have earlier told that we try it with 4 mm shot. Sometimes you do not get a good cysternal length. And in those cases, you need to safeguard the brainstem from unnecessary radiation. So you may need to do a beam shaping. You may need to block some of the sectors. In those cases, it provides equal pain control, but it exposes a longer length of the nerve to the radiation, to the 50% isodose. The integral dose delivered to the nerve is actually more in such a situation. So a longer volume of the nerve is getting the radiation. So the pain control would be good, but the hypoesthesia might be subtly more in such cases. When SRS fails, the next option is MVD. There is no complication in operating on prior SRS patients. I have myself operated on few of them and did not find any unusual trouble. But on occasion, the arachnoid might be a little thickened. As we can see in this case, I had a thickened arachnoid over here, and it took a long time to remove it. And the atherosclerosis of the vessels might be seen. Overall, there is no difference in the outcome of the patients with the prior SRS, and the results are good. One question, depending on the radiosurgery machine you have, whether you would like to go with an isocentric versus a non-isocentric treatment, means whether you are going with a gamma knife or a cyber knife. So the pain control is comparable to the gamma knife with the cyber knife, but the long-term rate is also high, and a non-isocentric treatment of trigeminal neuralgia with cyber knife leads to higher sensory complications. So this slide is courtesy Professor Alfredo Conti, and we can see that these patients had a significant failure rate, somewhere around up to the range of nearly 33 to 66% for the different duration they have been found. And this is actually all these sensory complications are more with the cyber knife in comparison to the gamma knife. Because in cyber knife, the whole of the length of the nerve is actually irradiated rather than a point. And this significantly changes the complication profile. Nearly there is a twice high rate of the hypoesthesia compared to the gamma knife radiosurgery. This is because of the Flickinger effect. This is a known concept. The sensory neuropathies are dependent on the integrated dose to the exposed structures. This remains the reason for the higher complication rate in cyber knife compared to gamma knife. As in gamma knife, you put a point dose radiation and exposes the shorter lengths compared to the cyber knife. Flickinger mentioned this phenomena that the longer length of nerve exposed to 50% isodose radiation, there are more chances of hypoesthesia with similar control of pain. Similarly, Kennett in 2004 told that exposing longer lengths have no benefit. Another query which was historically refuted is why not irradiate the ganglion rather than the cisternal component of the nerve. Ganglion in appearance looks a powerhouse too. It was the first target used by Lars Lexel. Recently, a Colombian group also used gacilin ganglion and concluded that gamma knife on trigeminal ganglion appears to be a reasonable treatment option with a short latency period, minor collateral effect, and higher percentage of the pain control. But it has been historically refuted. The prior literature and the historic anecdotes do not support it. And even I was amused by the acknowledgement of Dr. Roman Liskek, thankful to Roman Liskek, who provided insight and expertise, but he may not agree with all of the interpretations and conclusions of this paper. So I also do not agree to this article. The controversy these days is the dose rate of the gamma knife because the source is continuously decaying. So your patient might get treated when the source was new, or it may get treated when the source was old. So to determine whether the radiation dose affects the clinical outcome in patients who undergo stereotactic gamma knife radiosurgery. So there were two groups, the low dose rate group and the higher dose radiation group. The pain control, the median duration of the pain control, sensory complications, everything was actually comparable in these ones. But these days, we are more and more talking about the biological equivalent dose and the point dose radiation with the trigeminal neuralgia. The BED indirectly denotes the cell killing property of the radiation, and there can be a great variation with the same dose among different patients because cobalt-60 is decaying over time. We use sector, beam blocking. Treatment might be interrupted. There might be differences in the individual patient appearance, and the biological effectiveness of a given radiation dose decreases with the longer treatment time. So the optimal BED range for 90% probability of pain relief and less than 10% risk of the hypoesthesia has been reported 1805 to 2105. Constantin with Ian Pedic tried to evaluate if the treatment time affects the outcome, and this has been a matter of debate. They found that the pain-free status developed more slowly at the lower BED values. So giving 90 gray and 75 gray might be same if the BED is different and the treatment time is different, but it needs further analysis, but this is an interesting concept. Similarly, we sometimes find shorter lengths, sometimes longer, sometimes good volume nerve, sometimes atrophic nerve. Giving same dose radiation may have different effect in different patients, hence it gives the concept of the integral dose, that is how much volume received how much dose. So in between the time when the trigeminal neuralgia treatment was evolving, there were other treatment options such as the glycerol, rhizotomy, radiofrequency ablation, balloon decompression, microneurosurgery, and gamma knife. Stereotactic radiosurgery initially went into sabbatical for a long time until we improved in the radiology and the gamma knife technique. Now we know that we do not have a panacea for this disorder. Even the MVD fails. In today's audience too, there might be many people who practice many techniques for this disorder. Every procedure has its advantages and disadvantages, but as far as safety is concerned, there is no parallel to gamma knife. Gamma knife provides equal pain control with minimal sensory complications. There is hardly any chance of corneal hypoesthesia, dry eye syndrome with gamma knife. The only rider is that patient may need to take some drugs for longer time, as only 30 to 40% patients achieve BNI 1 status, that is the pain control without any drug, and rest need to take some drugs, though at a lesser dose. So compared to microvascular decompression, radiofrequency, and gamma knife remains the safest with a comparable outcome. So this is a 5-year pain control. The MVD, as far as the long-term pain control is concerned, it's little inferior to MVD. The literature review gives so, but the quality of life is different, and the quality of life is nearly comparable with the gamma knife and radiofrequency ablation, though radiofrequency ablation provided a little longer pain control. There are multiple treatment options. If you compare various ablative treatments, the best long-term pain control was seen with RFL, but it also came with the maximum and bothersome complications. In its comparison, gamma knife comes with the safest outcome and comparable long-term pain control. In view of the unparalleled safety, the radiosurgery remains the most attractive option to the patients and the referring physicians. And in the list of the complications, you can see various complications: cerebral lesions, CSF leak, aseptic meningitis, fifth nerve sensory deficits, dysesthesia, anesthesia dolorosa, diplopia, and so on. The only complication, which is also at a lesser rate compared to the other techniques, is the sensory complication. Nearly 1/3 of the rate that we find with the RFL and other peripheral ablative procedures. Coming to the complications which may happen. The complications may happen with the non-isocentric treatment modalities mostly. It has been mentioned in some cases as of the cyber knife, as there was a radiation exposure to the brainstem because you expose a longer length and you are very near to the ORS. This may happen, this doesn't happen with the gamma knife because we target distally, and the chances of the unnecessary radiation exposure to the brainstem are pretty less if you make a good plan. In their Novalis-based experience, Salis found the Pons enhancement near res in some of those patients, and it was actually a positive predictor for the long-term pain control, but it came with sensory complications. In gamma knife, we do not find any such complication. This patient of the LINAC radiosurgery developed a brainstem necrosis, edema, and a tough time after that. So how to choose the correct path? To be true, there is no universally correct path. Despite so many options and so rich literature, treatment selection is mostly based on personal bias, physician's confidence, patient's perception, rather than the risk-benefit analysis. So there has been no algorithm. But if you search the literature, you find that the safety of gamma knife remains unparalleled. So whenever a patient comes with a medical management failure with an essential or multiple sclerosis, the gamma knife remains the first treatment option. If it fails, you can go with the second treatment options or a repeat gamma knife. If it is secondary to tumor, treat the cause and then treat the trigeminal neuralgia. Usually with the treatment of the cause, the trigeminal neuralgia is also treated. But if it is a very small tumor, you can treat the both with the gamma knife also. So to summarize, my strategy now is to follow the Marcy protocol, 7 to 8 millimeter anterior to brainstem with 80 to 90 gray. Try to keep brainstem outside the 12 gray line at maximum. Less than 1 cc of brainstem should be receiving 12 gray volume. And if sparing the brainstem is not possible, I reduce the dose up to 80 gray. If it is still not possible, I change the gamma angle to 70 or 1 in 10 and use the plugging to safeguard the brainstem. ISRS has provided the excellent literature review on this topic and the practice guidelines. And with the level 2 evidence, we can find that the single fraction SRS is better than hypofractionated SRS. The previous surgery is a negative predictor for the pain relief after SRS in the short term. This factor does not, however, contraindicate SRS. A neurovascular conflict is not a negative predictor for the SRS. It's present or absent. It's going to work. The minimal effective dose is 70 gray. Do not increase the length of the treated nerve. Use only 1 4 millimeter isocenter. Use 2 isocenters either continuously or concentrically, but it may cause a flickering effect. An anterior target and a posterior target have similar initial efficacy, but anterior target has lower hypoesthesia. And LINAC and cyber knife result in the higher bothersome hypoesthetic rate. So if you do gamma knife and cyber knife, the pain control might be same, but the patient may come to you again and again if you are treating it with the cyber knife or LINAC with the complaints of the pain of bothersome hypoesthesia. And we need to personalize the trigeminal neuralgia radiosurgery for each and every patient because every patient's anatomy is different. There is no golden shot or definite sweet spot. The adaptation to the anatomy is the key. The patient selection is a paramount. You should be realistic with the treatment options. And I always explain the outcome and the chances of the pain control in the long term and the short term. You should not give the treatment to the patient. Let patient buy the treatment with this. They should understand the complication profile, the outcome profile, and that decreases the chances of any kind of litigation, and treat the underlying pathology. And to keep the record straight, we should follow a prospective registry with the objective assessment criteria. The BNI 1 to 3A are good outcome. If it is beyond BNI 3A, it's not a good outcome. We should maintain a prospective registry for these patients. So once again, it's patient who takes the risk, not the surgeon. MVD is definitely the best, no doubt. Yes, it is, but it is safest. But is it the safest in your own hands? When we counsel, we often mention the complication profile, and well, the patient should know your own complication profile, not of Peter Janetta. The Charles Drake was phenomenal in posterior circulation aneurysm, but none else. That's why world moved to the coiling. Similarly, the results of trigeminal neuralgia with the MVD treatment had some complications, and every surgeon had their own complication profile. They should discuss it with the patient, and only then they should offer MVD to them as a primary treatment modality. So while offering SRS, be humble and realistic. Offer to the patients who are not in the pain crisis phase. If they are in the pain crisis phase, better to go with the ablative or MVD. Don't ensure BNI 1 status to each and every patient that you are going to be completely pain-free without any medication, because only 30 to 40% of these patients are actually going to be pain-free without any medication. Rest would need some dose of the medication. Gamma knife might be the destination or a part of their pain journey. So he may be completely pain-free for a very long duration of time, or he may eventually have a recurrence of pain in the long term and may need another treatment. We may actually fail in 5% patients. Patient may need additional procedures. And we are the safest. There is no doubt in it. When I counsel the patient about different treatment options and they ask me the complication profile, I tell them that gamma knife is the safest. Primum non nocere is with radiosurgery. So we are coming to the end of this presentation. And after this, I would like to know your opinion and what would you advise if the same disease happens to your friend? It's a medical refractory now. So would you like to go with SRS, MVD, RFA, or the balloon decompression? So we have 10 seconds to answer this query, and I would like to know about your response over it. Well, 100% would like to go with SRS. That's pretty impressive. So thank you very much. And these are some podcasts for the Hindi listeners and English listeners also. Thank you very much for your patient listening. And I'm sincerely thankful to my Medical Faces team and the radiation oncologist to be a part of this journey.
Thank you, Dr. Manjul, for the great insights. We can now open up the session for some question and answers, please.
Yeah, so I'm able to see here one question by Dr. Tahir Rafiq. So what is the major difference between CyberKnife and gamma knife radiosurgery? So I think I have answered this question in my slide, but I would like to go again. That in gamma knife, actually, we are a point dose radiation. So we are just targeting a focal point in the cysternal component of the trigeminal nerve. We are not irradiating the full length. So by this way, we are modulating the nerve at a point to prevent the this pain transmission. We stop this pain transmission by just hitting at one point. Compared to this, in CyberKnife, actually, it's a nodal targeting with the with the full length of the trigeminal nerve. So as I told you that both these treatment modalities actually give an equitable pain control. But since in CyberKnife, you are exposing the full length of the trigeminal nerve, the patient has a bothersome hypoesthesia and the sensory complication in a good amount of these patients compared to the gamma knife. A gamma knife patient remains pain-free, and most of the times they do not have any sensory complication. So in that way, the patient becomes comfortable. Dr. Aman Batish has asked me a question. So have you done redo gamma knife for trigeminal neuralgia? If yes, what was the interval between the two sittings? Yes, I have done. Nearly around 20 to 25 patients I have done a redo gamma knife. I try to keep a longer time in between these two. The minimum possible duration is 6 months. Actually, there is no definite answer what should be the minimum time. And I talked about this with the Mosgan Hodai and Konstantin, and they also find that a 6 months duration, because sometimes the nerve takes a longer time for the radiosurgery effect to appear. So ideally, it should be more than 3 years. But if the patient gets a recurrent pain in between, it's better to go with a 6 months and at least a 6 months interval. So there's another interesting question. Tendo has asked that, not sure if I missed this portion, the short placement with the gamma, which is the most advised or has the best result? Okay, so I'll come back to my slide again. I answered this question in the very beginning. So actually, there are European targets and American targets. So the target which the American targets follow, they usually try to target at the near the root entry zone. So we can see here that this is the cysternal component of trigeminal nerve and the ores is over here. The European targets, especially the Marseille group and the Sheffield group, they treat the distal cysternal component. By targeting over there, you get same pain control and the chances of radiation delivery to the brainstem gets less and the sensory complications are less. The Konzelka group, they initially targeted near the ores. The pain control was good, but the sensory complication was also high. So the preferred target these days is at least 6 to 7 millimeter away from the oversternal radial zone. By targeting that area, you will get a good pain control and the chances of sensory complications would be less. That's an interesting query, and it usually happens in the routine day-to-day practice.
So I guess those are all the questions that we have for today. In the interest of time, we've actually also reached the end of our allotted time frame for today. So thank you very much, Dr. Manjul, for your time this afternoon, for presenting and sharing those great insights. Our gratitude to the audience for spending time with us today, and we hope to see you at our next webinar. Thank you very much. Bye-bye.
Thank you, Karan. Thank you, the attendees. Thanks. Good day.